My name is Serria, and I'm an interventional pain physician here in Tampa, Florida. And I've had the pleasure to work with attorneys and chiropractors in the treatment of people who are injured after car accidents. And I've taken a liken to this because these patients are frequently more injured than they're given credit for, and they have injuries that last longer than a lot of people think that they would have an injury for a few months, and sometimes it turns out to be years.
All right, so we had the pleasure of, and Dr. Shia explained to us what he does and how it relates to collisions and auto accidents and other type of collisions. What type of other injuries do you see, or other types of incidents do you see? You mentioned auto accidents, but there's others, I'm sure. Can you elaborate more on that?
We see a number of slip and falls, motorcycle accidents, and we see a number of chronic pain conditions that you can find when you look in their history are the result of previous injuries like falls from trees and machinery accidents, etc.
Okay. What are the most common, and because you've been doing this now for quite some time, what are the most common injuries do you find that in your line of practice?
Spine injuries secondary to car accidents is by far what I see the most. I see an incredible number of rear-ending injuries from people who were texting and they failed to see the person in front of them stopping, and they rear-ended. And rear-ending injuries have very predictable consequences in terms of the pain and the injuries that occur.
Let's talk about that, because as a personal injury attorney, the biggest impacts that we see as far as auto accidents go, we have other moped accidents, scooter accidents, but is either rear-ended injuries or accidents, or left-hand turn ones. Those are the two most common, but the rear-end ones are the ones that we find that it's a lot of damage unless they get T-bone. So whenever you get a person that got rear-ended, what are the most common injuries that you find from those type of accidents?
Spine injuries to the neck, so the what we call the cervical spine in the neck is very frequently injured, and it presents with a variety of symptoms, sometimes with very severe headaches, neck pain, pain in the shoulders. Sometimes these patients even have something called vertigo, where the patient feels dizzy and the world around them turns constantly. Is not that uncommon to see that in a rear-ending injury.
Now, when you mention spinal injuries, because there's different types of spinal injuries as well, and different things that affects the disc, just walk us through what specifically do you find? Herniations, bulging, and some people have a misnomer of herniations is worse than bulging. If you could just kind of talk to us through that a little bit.
Yeah, there's a lot of confusion. In rear-ending injuries, the basic mechanism is what we call a flexion extension injury, where the initial motion of the patient is forward with a backlash, where there is a two very common injuries, one to the ligaments that support the neck and to the discs that are separate the vertebrae in the neck. And in those we see what is commonly seen as disc or heard as disc herniations, but the level, the severity of that herniation is what prompts the severity of the symptoms. So radiologists, they read a disc herniation in different ways, which can be confusing. In general, a bulge is a step prior to a herniation, so it's a very small herniation that is typically not causing symptoms, but that is not always true. Many times a disc bulge can cause symptoms of neck pain and sometimes of pinched nerves in the neck that cause pain down the arms or into the head. A herniation can be divided into either a protrusion or an extrusion, which...
No,
Yeah.
doctor, to continue on that, of course, but whenever, what exactly, and definitely go into the protrusion and extrusion and things like that, but what exactly, for everybody out there that doesn't know what herniation even is that the disc that comes out of place, or?
Yeah.
Okay.
Well, let me show you this, because I like to
Yeah, that
show
would
it.
be great.
I don't know if I can show the camera, but in the spine, there is the vertebrae. This is what you touch in the back. Whenever you touch the back of your neck, you touch this part of the spine. The bones in between are separated by a structure that is mostly a gel designed for cushioning between the bones. And they're supposed to be fairly aligned with the edges of the bone.
Sure.
A herniated disc is when that gel comes out of place, typically backwards where the nerves are coming out of.
Hence, creating pain going down your arms or something like that, correct?
Correct.
Okay. And so that's what a herniated disc is. What exactly is a bulge then? It's just a
Well,
small herniation?
a bulge is typically a smaller herniation.
Okay.
And then when a herniation is a protrusion versus an extrusion, what that typically means is a disc can herniate moving completely out, or it can break. There can be a tear in the fibers of the disc, and that gel comes out almost free-flowing into where the spine and the nerves are. And an extrusion is typically considered the most severe form of a disc herniation.
And logically, I would imagine if the gel or the liquid is coming out, it would cause pain. But why does it cause pain? Is it because, well, is it because it's hitting the nerve roots, or what is it?
Two main reasons.
Okay.
One, the mechanical aspect of the disc pinching against the nerve, so it's just pushing against it.
Okay, sure.
It's making his nice and big hole very small. And the other one is that a herniated disc is very inflammatory. It's very warm and red. It's angry.
Okay,
and
sure.
Everything it touches, it causes it to be red and angry as well. So when the disc barely touches the nerve, it can also cause the nerve to be very irritated and cause pain. That's why even small herniations that do not appear to be impinging mechanically on a nerve can still cause a lot of pain.
Okay. And doctor, what about, okay, so we covered bulging disc, we covered herniated disc. What other things that you find from impacts, from injuries, from collisions? Do you find carpal tunnel? Do you find issues with traumatic brain injury? That's something that is kind of a popular topic now that I would like to maybe discuss a little bit with you. And or do you find, or what else do you find as far as like injuries that you see on a regular basis?
Well, aside from injuries to the neck, the second most common injury is to the lower back, the
okay.
lumbar spine, and the mechanisms are fairly similar. And the most common injury also are disc problems. The discs are in the lumbar spine. The discs can be a little bit stronger than in the neck, but when they do herniate, they tend to tear more. So you see more disc tears
On the lumbar section?
in the lumbar section, particularly at the very lowest level, which is called L5S1. It's very typical to see a tear of the disc, which in itself causes pain. And let me explain that. When discs herniate, the disc itself usually does not hurt. What hurts is the pressure against the nerves. But when there is a tear of the material of the disc, then it is the disc itself that is painful.
Okay,
And it causes
sure.
a different type of pain, which is more in the back. It's not the typical pain going down the arms or the legs. And is common in auto accidents
Okay.
and not as common in other types of injuries, such as the typical herniations of lifting heavy objects, etc. You don't see those stairs in those cases.
And what if if the accident is a greater impact? I mean, do you see this heightened, or do you see other things that are affected as well? I know it's kind of a general question.
Yeah, there's so many possibilities,
Sure.
but for example, we see the injuries from the seat belt.
Okay.
Big bruises and then pain in the ribs in that area.
Okay.
The patients are breaking with all the strength they have, and then you see pain in their right knee because how strong they try to break that car.
Yeah.
And then some of them are going to have traumatic brain injuries because particularly when they're not wearing a seatbelt, they can go against the windshield or even the steering wheel.
Sure, and we see that in our practice as well. So let's talk about traumatic brain injury, and then let's go into the procedures that you do to try to fix some of these ailments. So traumatic brain injury, and I understand when you have a whiplash motion, either side to side or forward, there's a liquid, and you can, of course, you know a lot more than I do.
Yeah.
We just help people recover for their injuries, but a liquid inside that protects the brain a little bit, but because of the impact, it crashes back and forth in the skull walls. But if you can just kind of elaborate more on what you've seen on the traumatic brain injuries.
Well, the brain is swimming in fluid.
Okay.
And there is a number of structures that are anchoring the brain down to the neck, etc. And those are the structures that tend to be stretched by the motion of the brain inside the skull. In this deceleration injuries, you're going at 80 miles per hour, and all of a sudden you're at 0 miles per hour.
Of course.
Your brain wants to keep going, and when it does, it stretches a big number of possible structures inside your skull that can cause the traumatic brain injury. There could be even bleeding from that.
Now, and I've heard the statistic, and I don't know how true this is, 70 to 80% of CT scans miss traumatic brain injury because CT only shows if there's hemorrhaging or blood in the brain. But have you heard anything of?
Yeah, CT scan has a very low sensitivity for traumatic brain injury, unless there is a bleed, which is thankfully not very common because of how strong the skull is.
Of course.
You don't see evidence of traumatic brain injury in a CT scan, which is what is typically performed in ERs.
What do we see? What are the common, if somebody was out there, what are the common symptoms, I guess I would ask? If somebody said, and you know, we've heard, I just don't feel right, or I feel dizzy, or what have you found as the most common symptoms of when you?
Well, the patient would have an initial loss of consciousness at the time of the accident, and then when they come back, they like you said, they don't feel right. They feel dizzy. They feel this vertigo, like everything is moving around.
Okay.
They can have a severe headache, and then, which is the most concerning, is that these symptoms may dissipate initially, and then they would start having chronic symptoms of traumatic brain injury, which would even include emotional liability, problems like that. Yeah.
So a lot of times focusing, maybe connecting with loved ones, you know, the vertigo, standing up, mood swings, okay, stuff like that. Yeah, because a lot of people, I think that they're not really thinking about this traumatic brain injury issue, but it is happening because even at low impacts, we've seen that it does affect people's mood. They just don't feel right, and they feel off. That we've heard
for months.
Months,
and they don't understand why it's happening. That nobody's told them they could have a traumatic brain injury, and they just can't get back to their lives, and they don't know why.
Of course. And doctor, we're gonna, and I have a list here, your phenomenal, worker with you here, Rich, he sent me a nice list of all these common, procedures that I don't even know what they are. So this is a very educational experience for me as well.
Okay.
But it makes it very easy for us to explain this to our clients, and it makes it, it's like a pre-op, I guess, just kind of tell them what that is, because people are scared of surgery.
Sure. Yeah.
So some of the common things I like to bring up is MBB, medial branch block. What exactly does that mean?
Let me use the spine once again. The MBB stands for medial branch block. The nerves that give you the sensation of the structures in the spine and the back. When you have one of these injuries, you could have pain in the back.
Okay.
And those little nerves can be treated with a needle-based procedure where initially we do an injection of anesthetic that's going to numb those nerves for a number of hours, and if those patients get enough relief from that test, then they're going to come back and we're going to put the needles in the same place, but this time we're going to put a wire through those needles connected to a generator that gives up this type of energy called radiofrequency.
Okay.
Which what it does is a stun gun, like a taser gun effect on those nerves, dumbs them down for months, usually 6 months for a year, and the patient feels relief of the pain of those structures in the back that are in the process of healing from the injury, but are hurting tremendously. So the patient gets pain relief, and many times by the time the effect is wearing off,
They're healed.
They're healed.
Okay, good. So it's so a lot of times people may think it's a Band-Aid, but what you're saying that their body is still healing in this whole process, and they may not have to do this forever. May not have to do this forever, depending on
They
how their
may
body
not.
may not.
Correct.
Exactly. We never have it exacts in law or medicine, because that's a liability waiting to happen. So let's look at RFA, radio frequency ablation, I think it's called.
Radiofrequency ablation. That's what we just talked about.
Oh, okay.
So
Okay,
the
perfect.
second step after the medial branch block, which is the test, is the radiofrequency ablation. The needles directed to those nerves that supply those structures in the back, and connected to a generator to give that taser gun effect on the nerves.
Now, is this all happening? Okay, just like, and that way I can get a visual of this. They come in. Is it like is it a shot, or is it like an actual procedure, like a surgical procedure, or is it?
No, it's not a surgical procedure. The patient is on an X-ray table.
Okay.
We do this procedure guided with X-rays, and the patient can be asleep because we're a level 2
Level 2, yes.
surgery center.
Yes.
And when the patient is asleep, I'm going to use needles.
Okay.
So it's not really surgery. The needles are going to be directed to these areas of the spine.
Okay.
And then, with the patient still asleep, I will connect the wires.
That's outside the body.
That's
So the needles are
yeah,
sticking
only
outside.
the needles,
Okay,
right?
gotcha.
Only the tip of the needles are inside. Then the other end of the needle is going to be outside. We connect the wires from outside. We turn on the machine, do the lesion, which takes about 90 seconds, and then we pull everything out.
Sure.
And the patient goes home usually in less than 15 minutes.
Wow, so it's fast. It almost
There's not much downtime either.
it almost reminds me of acupuncture, but a little bit more invasive. And acupuncture works pretty well because of the needles. But I know it's a little bit different because you're going deeper in.
Yeah, this
the
one
problems.
is targeted to the specific pain generators
Sure.
in the back. Yeah, but
Okay.
yeah.
So it's very targeted.
It's very targeted, and this can be done in the lower back, and the neck, and the mid back. Any area of the spine where we have this structure here, the what we call the posterior part of the spine, or the back, basically.
Now, will the clients lose or the patient lose sensation, or can they still continue with their regular lives? Because if you're
Right.
numbing the area, or you're
Yeah. Great question, and I love to answer that because that's why we do radiofrequency ablation. Radiofrequency has the ability to target specifically the pain component of the nerve without causing any effect on the sensation. So the patient's not going to be numb or anything like that.
Okay, good.
And also, they're not going to lose strength. They're not going to have a weak back. The muscles are not going to stop working for a period of time or anything like that.
Okay.
Yep.
Okay, perfect. Yeah, because
And I would love to explain to you why that is. That we may not have the time, but if you have time, I'll tell you.
Yeah, I mean, if you want, we have a couple things that we have on the list. Maybe if we get time, we'll go back to this and, you know.
Okay.
The other one is a
Transforaminal.
Yeah, epidural steroid. What exactly is that?
Well, epidural injections are, you know, I think everybody has heard of them, but most people do not understand what they do. Even people who perform them, I don't think they completely understand what they do. Epidural steroid injections, what it really is injecting steroids, which is a very potent anti-inflammatory, and usually the steroids are long-acting. They're going to act in the spine for weeks. And what we want to do is to reach these nerves that are coming out. These are the nerves that are going to be impinged on by those herniated discs, either in the neck or the low back. And they're going to be irritated. They're going to be swollen. They're going to be angry. Okay, we want to calm them down with a steroid. Okay, when those nerves are swollen, they're fat, and therefore the impingement of the disc is even worse.
Sure.
It's like biting the inside of your cheek. When you bite the inside of your cheek, it gets swollen, then you keep biting on it, so you can't get rid of it. So that's the purpose of a steroid. However, most people do the epidural injections from this approach, from the middle, okay? Which cannot always reach these nerves on the side, because remember that there's a disc that is impinging on it, so it might prevent the spread of the steroid.
Okay.
So the transforaminal injections, what they do is we go from the side and we target the specific nerves.
That seems to make sense. Actually,
it
seems to make more sense than going the other way, but.
Yep. And we get much better results with that approach.
Okay.
That's another type of procedure where the patient can be asleep. They don't have to be awake. They don't have to feel any of this.
And when we say sleep, sleep here at the level 2, of course. Whenever we say asleep, we're not talking about general anesthetic. We're just talking about
sedation.
Sedation. Okay. Because I know a lot of people are scared of being under. You know, that's
correct. Yeah, no, we don't do general anesthesia. We sedate the patient with a type of sedation that is very quick to get in, and also very quick to get out. So the patients are usually functional within 15-20 minutes, and they cannot drive home because that's the law. But they're going to be wide awake and hungry and ready to have lunch. And,
oh wow!
Yeah, very quickly.
Imagine that. Getting this done, going to West Ham Sandwich Shop after that.
Perfect.
And what is this annuloplasty? What is?
Annuloplasty is a procedure targeting that tear in the disc that I was telling you about. That is a very common injury that I see after car accidents, and not as much in degenerative disease of aging or anything like that in the spine. I see it particularly in patients who have been through a car accident.
Okay.
There is a tear of the fibers in these discs right here. Okay. And that tear itself is painful. So the annuloplasty consists of, through a needle, it's a big needle, we call it a cannula, but it's still a needle, it's not surgery. Okay. We get to the disc and put a little probe, like a wire, around those fibers that are broken, and we turn on a type of energy that is going to cause the fibers to coagulate. Okay. In other words, we reseal the tear.
Oh, okay.
We repair the tear.
Okay.
And in addition to that, the little nerves that are very hyperactive there, they also get treated in a similar fashion to what they do with the radiofrequency ablation, and you get a sealing of that tear that occurred in the disc.
Okay. This is kind of exciting stuff. It's almost like have you ever seen, you have kids, I have kids too. Like Wolverine, have you ever seen how he heals and
Yeah,
yeah.
how it heals.
It's kind of like
immediately.
you're creating, you're putting the body in a state that it can heal itself and like you said, regenerate and with electric and it's
But
taking pain
that's
management
what
to
we're
a different
looking
level.
for. We're looking to heal without the need for more invasive approaches like surgeries.
So all these are great alternative surgeries. Is that a correct statement?
That is correct.
Okay.
That is what we do.
And let me see. And paracutis disc some of these words I have no idea.
Percutaneous disc decompression.
I'm glad you know it. Yeah, I hope so.
That is an alternative
Sure.
to the surgery for a herniated disc.
Okay.
Some types of discs, not all of them unfortunately, but some types of herniated disc can be treated without surgery.
Okay.
When the disc meets certain conditions, we can go again with a cannula, a big needle, and we put a little drill through that cannula into the disc in here, okay? And when we get to the center of the disc, we drill a few, we call them channels of destruction.
Okay.
And what we create is a lesion in the middle of the disc. That lesion is going to create a scarring process. And that scarring process, like any scar, is going to retract.
Exactly.
And so it retracts the herniation.
Okay.
And you get the symptoms go away very, very quickly. And there is no further need to do anything else.
Okay.
Now, you cannot do this on every herniation. So many will still need surgery. So we have to evaluate the individual case to say.
Okay, but it is a great alternative, and then it depends on the person whether or not, and that's something that they would have to come in. You have to check them. You have to do an MRI, I imagine, or X-rays and.
We absolutely need the MRI, and we need to see what the symptoms are, and it's also very important to know if there's more than one disc that is herniated.
Okay, okay. And then we have spinal cord stimulation in regenerative medicine.
Spinal cord stimulation is one of my favorite ways to treat pain. It's not very well known, and it doesn't make sense to a lot of people, but what it is basically a pacemaker for pain. It's, I don't know if we can see it here, but it is a little battery that causes impulses that are taken to the spine through these wires. And they're going to go to the spine, and they have an effect, a very subtle effect on the nerves that are going into the brain. Okay. From the back, for example. It can also be done in the neck and the mid-back. And it can alleviate pain that is otherwise not responding to anything else. And beyond that, it serves two major purposes. Avoid surgery, okay, on particularly on patients that have disc lesions that produce mostly the pain that goes down the legs or down the arms. And also it can rescue patients who have persistent pain after undergoing surgery. Okay. As you know, spine surgery has a high incidence of persistent pain. Sure. After the surgery, and spinal cord stimulation can really help that. So patients who are looking to avoid surgery but they're having pain, they had an injury and they continue to have pain, this is one of the alternatives that I can offer them. And those who did have surgery and continue to have pain, this is many times the only choice they have.
I think when a lot of people, when they think of pain management, and myself included, especially before I was an attorney, was they think of prescription drugs and pills and things like that, but this is completely different. This is more of a really get in there and help the person, not so much cover up with medicine.
Yeah, the probably the basic mission of interventional pain medicine is to avoid patients from being on chronic opioids. Chronic opioids have not been shown to have a true change in the quality of life of patients long term.
Sure.
And because they can produce a temporary improvement, they tend to get a lot of people hooked, and then they're taking these medications and they can't get out because they're addicted, and if they get off, things gets worse, and then they get into this vicious cycle that in the end doesn't help them.
Yeah,
so we
it's
try
a
to
vicious cycle,
keep
I
them
agree.
away from that.
Okay, and I think there's one other topic here, and I know you have clients here pretty soon, and the other one was CRPS, complex regional pain syndrome, and then maybe we can touch on the other subject.
Regenerative medicine.
Yeah, but let's touch on the
a lot of people, but not everybody has heard of RSD, reflex sympathetic dystrophy. It's a terrible condition.
Okay.
Thankfully enough, it's not very common, but it is the result of injuries.
Sure.
And I have seen a number of cases now in car injuries, slip and falls, and other types of injuries. It is very complicated to understand, but it was called RSD, and we changed the name to complex regional pain syndrome.
Okay.
And what it is a nerve or a group of nerves that after a minor injury decide to undergo a transformation where there's going to be pain and many other symptoms completely out of proportion to the inciting injury. So you could have a small fracture in one of your fingers.
Sure.
And develop CRPS and completely lose function of your arm because of pain.
And I'm sure a lot of doctors, before, they probably think that one thing has nothing to do with the other, but now we're finding that there is a correlation of something small that can affect something larger.
Yeah, no, it is well established. As a matter of fact, in the diagnostic criteria, that is one of the primary things that you need to fulfill is there is an injury that is out of proportion to what the pain is now.
Okay.
Well, let me give you some perspective. You could get RSD, CRPS from a mosquito bite.
Wow.
Yeah.
And we live in Florida, so that's dangerous. Imagine that. I would hate that.
But the most common reason is orthopedic injuries in the extremities. CRPS usually occurs in the extremities, so the hands or the feet or the legs and arms.
That's interesting to me because, dealing with insurance companies and dealing with opposing counsel and adjusters, a lot of times the client comes to us and says, I have all this pain, I have a lot of pain. And the adjuster says, well, it's a small bulge. They can't have that much pain. It's malingering. It's fake. And so what we're finding out now, what I'm finding out is it's not that. It's the fact that it could also be what you're speaking about.
The victims of yeah, but beyond that, this is something that we see in pain medicine all the time.
Sure.
We're always struggling for objective findings about pain medicine, and it is chasing your tail.
Sure.
There are a number of injuries not only injuries, reasons for pain that do not look severe enough to cause the amount of pain that a patient complains of, and they occur every day.
Sure.
You have a patient with a disc bulge that can hurt 10 times more than a disc herniation. I see it every day. And yes, when you see that patients' injuries are minimized by payers or insurance companies, etc., because of the lesser objective findings compared to the patient's symptoms, it is very difficult sometimes to treat these patients because you can't get their treatments
Well,
performed.
I mean, and that is interesting, because the adjusters, they try to play doctor when they're adjusting claims, but
Yeah.
that person, that's just a claim number to the adjuster, is actually feeling these problems forever. It affects their, we find it affects their daily living activities, playing with their kids, brushing their teeth, like the little things that we take for granted. And I don't think a lot of people really understand that, and you see it on your side.
No,
But,
but most of my career I did at Moffitt Cancer Center, so I was treating cancer patients for many years. And when you're treating cancer patients, you never have these questions. If somebody has cancer, they tell you they have pain, you don't question it.
yeah,
So when I came into private practice, I came with that bias.
yeah, it's a paradigm shift for sure.
Yeah, and I've changed my perception. These patients are really hurt, and they're treated as if they are malingering. They are looking for a settlement or something like
Of
that.
course.
And many they're injured. They're hurting. They come to my office saying, I mean, I'm not the same person. I can't get back to my life. I can't sleep. I cannot do the things I used to do. What can I do?
Of course, yeah. Let me see. Tell me more about going back to the initial thing that you spoke about, that you said you're going to elaborate more if we had a little bit extra time.
Radiofrequency ablation. Yeah, you asked why radiofrequency ablation will improve the pain, but will not cause loss of sensation and weakness and all the other functions of a nerve.
Okay.
If you have a nerve, if you have pain in your hand, you could cut the nerve to that hand and maybe be out of pain.
Okay.
But you're not going to feel anything in the hand. You're not going to be able to move your hand.
Okay.
Either, right? And as a matter of fact, sometimes by doing that, you can make the pain worse. But that's another topic.
Okay.
But you can treat a nerve with radiofrequency ablation and get rid of the pain and not cause the loss of sensation and the loss of motor function. Why is that? Because nerves are like an electrical cable. And within that electrical cable, there are fibers that are going to the brain, to the area that feels the pain. Others are going to the brain, the area that has a sensation of the tactile sensation, what you feel of heat, of cold, pinprick, etc.
Okay.
Radio frequency has a predilection for the fibers that take pain to the brain.
Okay.
And it can cause them to degenerate. It kills those fibers without causing any damage to the motor or the sensory fibers. The reason for that is interesting is because of, have you heard of the myelin sheath?
Oh, yeah.
That patients with multiple sclerosis have a deficiency of is the, if you think about an electrical cable, the myelin is the plastic around it, is the plastic sheath. When you lose that, you lose protection. All of those little fibers, they have that myelin sheath except for the pain fibers inside a nerve. And the reason for that is because of evolution.
We need to be able to feel pain.
Well, the pain fibers are the oldest in evolution. The most primary survival need we have as beings in the world is the ability to get away from harm.
Yeah, like hot stove and things like that.
Yeah, if you think about a parasite, with one cell parasite, they don't feel pain, but they can sense something that is toxic to them and they pull away.
That makes sense.
So those fibers are so old that they never developed that sheath, that protective sheath. So
Okay.
radio frequency, you can graduate it so that it will harm the fibers that don't have protection of the myelin, and
Okay.
you can have the other fibers intact. So that's why radiofrequency ablation works so well for treating pain.
Now, I know
I
it's a
hope
growing.
it wasn't too technical.
No, you're fine. You're fine. And I know there's a growing trend in stem cell. In fact, and I did. I have a shoulder injury, and they did what is it, PRP? PRP in my shoulder, and then they mentioned to me that if that doesn't heal, the next step would be stem cell. But you do stem cell as well.
Yes.
And tell me more about what that means.
Well, the PRP, which is plasma, platelet-rich plasma, I'm sorry, and stem cell therapy, we collectively call regenerative medicine.
Sure.
And is in its infancy. We're just starting to see all the potential and uses of it. But I do believe that it is by far the future of orthopedics.
Sure.
With stem cell, you can regenerate cartilage.
Okay.
The arthritis is the degeneration, usually by age or overuse, of cartilage, which is the surface of joints.
Okay.
When you lose that, as of now, you can't get that back. So once you have arthritis, you can't get it back. Well, stem cells, you can inject stem cells that are going to grow into new cartilage. Imagine,
oh, wow. So
you're 80 years old, your knees hurt all the time, they crack every time you move them, and then I come with a needle, inject a few stem cells in your knee, and they repopulate the cartilage. They create new cartilage, and now your knee is like a 20-year-old knee.
It's like the fountain of youth, kind of, because I mean,
Yeah.
like I know that I have pain in my knees and my shoulder, for multiple things, and I'm sure, I'm sure I have arthritis somewhere. But that's pretty interesting to me because a lot of people, especially in personal injury, they want to say it's arthritic, and sometimes it is arthritic, sometimes it's not arthritic. But this is taking it to another step because now not only are you treating their pain, you're able to treat the arthritic condition to repair that. So
Correct.
you could almost, well, I mean, that's a far statement, but you could almost rebuild the person, as far as in that area.
I mean, as a potential, absolutely. I mean, you can. What happens to us when we age? We lose our cartilage. I mean,
Yes.
arthritis is what ages us.
Sure.
When you're 80 years old, you can have a great heart, great lungs, great kidneys, but your bones, your joints are suffering. And if we could regenerate those, imagine all the things that we can achieve. Maybe we can live 120, 130 years.
Wow. Yeah. So
I don't know if that's a good thing.
So as long as your organs are functioning properly and your blood flow and things like that, I mean, you could essentially.
You could have a good life even as an elderly person, which is, we work all our lives hoping to retire. And then when we retire, we can't move, can't do anything because of arthritic conditions, etc.
And arthritic conditions also come from car accidents, is that correct? Or
No, in car accidents, what the uses of regenerative medicines are to repair broken ligaments and tendons, because the tears from those, they take a very long time. We're talking years. A very common example is a whiplash syndrome in the neck after those rear-ending accidents. There's a lot of tears in those ligaments that can take years to repair, and through those years the patients are suffering with pain in the neck, headaches. These regenerative medicine can accelerate the recovery of those ligaments, weeks of recovery in the knees. Another very typical one is tennis elbow, for example, which is contrary to what you may think. It occurs mostly on injuries might be personal injury, etc., not so much in tennis players.
I can see that. I mean, weightlifting, I can see that too. Like, is that when you extend your elbow? Yeah.
All the time, yeah.
I feel
Those
like
who
I'm
are
getting
doing
old, I think.
dumbbells like this,
Yeah, I know.
then that tennis elbow is
Painful.
a time bomb. Yeah.
Sure. Well, Doc, I know it's about that time for you have clients. Is there anything you'd like to conclude with, anything like that before we end the video?
No, I would like to thank you for giving me the opportunity to talk about this. I'm very passionate. This is somewhat new to me, and I believe I can help a lot of people because I'm bringing a different perspective than what I see currently done in the community for these patients. These patients are hurt. These patients need help, and I can help them.
Okay. Yeah, no, I appreciate you, and we'll make this live on Facebook, or not live, but we'll upload it and then we'll break it into little sections, and that way we can keep educating our community, because I think that the problem with attorneys in particular, and in the profession that we're in, there's a lack of education. It's all ads to call you, but we're not educating our community on what happens when this happens. And I think that if we can provide those resources and provide that information to people, it's valuable, because now they know what they're getting themselves into, and they can understand the process better instead of having this constant doubt of what's happening. So I appreciate your time, and I'm really educated on this now too, because I've learned a lot of things now that I never knew. So it's very educational to me, which makes it easier for me to talk to my clients as well, and saying, I'm not the doctor, again, you have to see, they can tell you what to expect, but these are the different procedures that are alternatives. You can check it out, and that way they can make a better informed, educated decision. I think it'll be
Yes.
good for everybody. So
I'm very glad that you feel that way, because these patients, they look up to their attorneys, and they trust them, and they trust that they are guiding them with their best interest in mind. So I really appreciate it. Thank you for giving me the opportunity.
yeah, thank you so
I will
much.
see you soon.
Yes, thank you.